powered by Jumpstart event. It is an exciting day. For those of you who are not aware of the Calgary Adapted Hub, we're a collective of Calgary-based organizations committed to providing quality, evidence-based sport and recreation opportunities for children and youth and families living with a disability here in Calgary. Please keep your eye out for our website and social media launches in the near future. Before Cheri begins, just a few housekeeping details, and then we'll get going. So just so you're aware, we will be recording this seminar. Live transcript is also available. If at the bottom of your screen you look, there's an option that says live transcript. Click on that button and click show subtitle, and you'll be able to see closed captioning. To avoid any background noises or interruptions, if you could please ensure that your microphones are muted throughout the talk, and there'll be opportunity for questions afterwards. We'll use the chat function or the raise your hand function just to make sure we're not interrupting each other. Now, we are so grateful to have Dr. Blauwet here to kick off our monthly Calgary Adapted Hub Research and Community Engagement seminars. Leading up to today, I've got to tell you, Dr. Blauwet, I've received countless emails and been told by so many people how much of a superstar you are, and I'm thoroughly looking forward to hearing you speak. Dr. Blauwet is a physical medicine and rehabilitation physician, an assistant professor at Harvard Medical School, and an attending physician at the Brigham and Women's Hospital and Spalding Rehabilitation Hospital. She serves as director of the Kelly Adaptive Sport and Research Institute. Dr. Blauwet is also a former Paralympic athlete in the sport of wheelchair racing, competing for the United States team in 3 Paralympic Games, bringing home a total of 7 Paralympic medals. She also is a 2-time winner of both the Boston and New York City marathons. Translating her background as an athlete to the clinic setting, Dr. Blauwet was the past chair and now serves as a member of the International Paralympic Committee's Medical and Scientific Committee, and serves on the board of directors for the United States Olympic and Paralympic Committee, as well as numerous other leadership roles throughout the Olympic and Paralympic movement. In 2016, she was the recipient of the Harvard Medical School Harold Amos Faculty Diversity Award and was named one of Boston's 10 outstanding young leaders by the Great Boston Chamber of Commerce. In 2019, she was named by the Boston Business Journal as one of the 40 under 40 community leaders. She's become a global advocate for the use of sport and physical activity to promote healthy lifestyles for all individuals with disability. She was a guest at the White House, as well as a keynote speaker at the Boston celebration of the 25th anniversary of the Americans with Disability Act. As I said, we have a superstar among us. So without further ado, Dr. Blauwet, take it away.
Thank you very much. And thank you for this warm welcome. And I'm so excited to be here to kick off this speaker series and this opportunity to bring more knowledge translation and just, education and opportunities for discussion and networking to the adaptive sports community. So thank you again for the invitation. All right, and I'm going to share my screen. Can everybody see that? All good? Great. Okay, so we're going to take a little bit of a journey tonight. The title of my talk is From the Paralympics to Public Health, the Impact of Sport and Physical Activity for People with Disabilities. As was noted in the introduction, I am a retired Paralympic athlete. I do a lot of work in the Olympic and Paralympic movement, thinking about things like elite athlete health, injury and illness prevention, all those very important topics. But I think it's important to remember that all of that work ultimately informs how we think about community-based adaptive sport and promoting health for people with disabilities. And so these concepts are very interlinked and interrelated, and hope to provide some context for that discussion this evening. Just a brief disclosure slide, noting that I do receive some grant support from the Research Institute, a foundation grant, National Institute on Disability, Independent Living and Rehab Research, which is through the NIH in the US. I sit on the scientific advisory board for an app that promotes recovery programs and several leadership roles as was outlined in the intro. So I think the central theme of this talk is this. We're in the midst of a paradigm shift across the US, across Canada, really across the world, in which we're really trying to redefine the concept of disability and move past this medical model where we consider people with disabilities to be ill or inherently flawed, or individuals who are under that medical paradigm, right? And we're trying to shift that mindset into one in which we think about disability as more of a civil rights movement and a human rights movement. And when we think about um, adaptive sports opportunities, whether at the community level or at the elite Paralympic level, I think so much of our work is important in the opportunities that we're providing to young people, to adults with disabilities, and offering equitable access to sport, but or also shifting societal paradigms about what disability means. And when I think about from the Paralympics to public health, to me, we're encapsulating the power of all of these more progressive movements like the Paralympics, but the impact that they have on both opportunities for physical activity engagement, but also shifting that paradigm globally, which of course is so important. All right, how will we get there? So I'm going to provide an overview of disability and health disparities, share a little bit of data about what we know about people with disabilities and the impact of sedentary lifestyles, as well as a brief review of some of the known barriers to engagement in physical activity. We'll talk a bit about sport and physical activity and whether we think of it as like a rehabilitation intervention or more of a rights-based opportunity. What's its impact? What are the potential drawbacks? And is it really a privilege or is it a right? We'll talk about promoting access and opportunity through the lens of universal design, and then ending with a call to action. All right, so when we think about disability and health disparities, it's incredibly important to note that, of course, so many people in our communities, young people, older individuals with disabilities are far too sedentary, right? And that's a very complex challenge. It's multifactorial, related to things like community barriers and lack of opportunity, and also, again, this mindset and this stigma that leads us to think that if you have a disability, you can't be active, right? Which I think those of us on this session tonight probably understand is not true. But what's the ultimate impact? So when we think about people with disabilities globally, and we think about the potential public health impact of getting people moving, it's important to understand the size of the disability community. Globally, 15 to 20% of individuals are individuals with disabilities, and that's over 1 billion people. In the US, this is over 50 million individuals, and we can see from this figure from the CDC that disability, broadly defined, very much clusters with chronic disease. So disability is both a cause and consequence of chronic disease. And the Institute of Medicine in 2007 published a report on disability in America and coined this phrase, which applies to the US, but I think applies more broadly as well, that disability affects today or it will affect tomorrow the lives of most Americans. So disability touches everyone. Whether it's transient or permanent. And when we think about promoting and expanding opportunities for physical activity for people with disabilities, we can see through some of these numbers and understanding that disability does affect everyone, that this is really a public health issue. So there's been a lot of initiatives to promote physical activity more broadly. Here's a few examples. The American College of Sports Medicine promotes a large campaign called Exercise is Medicine. Large sport leagues, like here in the US, the National Football League have a program called Play 60, where they're trying to promote 60 minutes of physical activity daily for young people. The US federal government puts out healthy people goals, initially 2020, and now there's new goals for 2030, of course. So we know that there's broad public health campaigns that promote physical activity, but the question is, how much do these meet the needs of people with disabilities? And I think it's easy to see that if we don't think specifically about how to tailor these opportunities for physical activity promotion to meet the unique needs of people with disabilities, that we're often missing the mark and aren't reaching the disability community. And we know that there are disparities related to sedentary lifestyles and the impact of chronic disease. This is a table that's really a compilation from data from the National Health Interview Survey, where it's a large population health survey where they try to assess self-reported disability, but then also basic markers of health. And within this survey, how they define disability is asking people whether they have any movement difficulty, emotional difficulty, seeing or hearing difficulty, or cognitive difficulty. And you'll see here that when any of these self-reported functional limitations are noted, that these correlate with things like being more likely to be obese. You'll see much higher numbers for individuals who self-report disability compared to those who do not. You'll see that people are more likely to be completely inactive and not engage in any amount of leisure time physical activity. And you also see on the bottom row there that that unfortunately disability also correlates with adverse health behaviors like being an active tobacco user. So we know that across the board there are disparities. This is just one small sample of the data. There's a lot more out there, but just wanted to provide that picture that if you really do take a look, you'll see that these impact the disability community at a population health level. In addition to the community being disproportionately impacted by the impact of sedentary lifestyles, unfortunately, we're not doing a great job of augmenting our approach, right, in the health profession, or thinking concretely about how we need to be even more assertive and assertive towards recommending physical activity for individuals with disabilities. The CDC published this vital signs report several years ago that really did a deep dive and looked at the literature around physical activity and disability and chronic disease, and just noted some fairly stark figures here, and also concerning, noting that only 44% of individuals reported that they received physical activity recommendations from a health professional within the prior 12 months. So there's a total mismatch, it seems, between how we know the community is impacted, but not rising up to change our behaviors in terms of trying to promote physical activity broadly. And what are some of the barriers? So, there's been a number of, fantastic researchers who have tried to do more to understand, have done investigations to understand, what are some of the barriers to physical activity engagement. One of the most well-known is a colleague, Jim Rimmer, who's currently at the University of Alabama, Birmingham, where he runs a large research collaborative, and he's been looking at this for decades. So here are a couple of highlights from his prior work, but I'd encourage you to just take a look at all that's coming out of that particular research group, because it's quite informative. This was a simple study that looked at individuals who had experienced a stroke and who had hemiplegia, and asked them about their engagement in physical activity, but also what they reported as barriers. And you'll see that coming in at the top of this list are things like cost of the program, not knowing where to find a program for adaptive physical activity, not having a means of transportation, or not knowing how to exercise or how to engage in physical activity. And I think this is an important figure because to me, what this says is that the things that are self-reported as being the largest barriers are all things that are modifiable, right? Things that we can change. We can look at programmatic cost. We can make it easier to find a program. We can facilitate transportation. These are things that we can tackle in our communities. And the things that are reported as barriers are modifiable, whereas the things that might be harder to change, like level of motivation, level of interest, not having enough time, or having inherent fears that it'll worsen their disability or condition, those things are far less likely to be reported. So to me, this is, I think, important to demonstrate the impact that we can have with community-based adaptive sports. One challenge and one barrier from my perspective is the heterogeneous nature of the population of people with disabilities and the way in which disability can be very dynamic and changing. And I think that does create a perception within the public health community and people who are thinking about physical activity programs, and it creates a level of intimidation that makes it, harder to implement these programs in many cases. And I think if you're someone thinking about physical activity from a public health lens, and you're thinking about, well, who do I target? Am I trying to build a program for a young adult with a new spinal cord injury, or an older individual, or a young adult with an intellectual disability? It's kind of complicated. And for that reason, I think that of course programs need to be very much tailored to the individual, but also I do think that this is a unique challenge when we think about physical activity programs for people with disabilities. Another barrier is difficulty in accessing both the natural and the built environment, and lack of universal access. This was another simple study by Jim Rimmer and his colleagues where they looked at 35 fitness facilities across the US, and did a survey and did an audit really from the standpoint of 6 major categories, as is listed here. And what did they find? Well, they noted that few facilities had full accessibility from the structural standpoint. So things like accessible showers and locker rooms, power assist doors, ramps meeting ADA specs. So there was more work to do there. Importantly, even if you could get into the fitness facility, for many types of people with different types of disabilities, there wasn't a lot to do once you get inside. And this is something that I know I've encountered over and over again in our communities, is that I can get into a gym, but once I get inside, there's really nothing to do, because the types of tools and equipment that are inside most public fitness facilities are very much focused on the able-bodied individual. Very few gyms have upper body cardio machines, for example. Many of them are crowded and don't leave a lot of floor space to navigate between machines if you're someone with an assisted device, or a power wheelchair, for example. So the equipment and tools that are within these facilities are also very important to consider. About half had pool lifts, and of course, aquatic exercise is an extremely important mechanism of engaging in physical activity, but it can raise structural barriers. Less than 25% had information available in accessible formats like Braille and large print. And they did assess this element of professional behavior and kind of cultural competency towards disability. And at greater than 85% of the facilities, the staff were aware that asking a person with a disability if they'd like help and simply going to the individual to understand what would best facilitate their participation was the best way to engage the individual. So that was seen as a very much a positive. And of course, accessibility of fitness facilities is extremely important to the disability community, because the natural environment also, has many barriers. And of course, there are many adaptive sports programs, I'm sure, some in Calgary as well, that really open up opportunities for outdoor recreation to people with varied types of disabilities. But at baseline, if one doesn't have access to these types of specialty adaptive programs, the natural environment in of itself is full of barriers. And so, we really have to think about approach where we're looking at outdoor opportunities, fitness facilities, school-based environments, and really thinking about all the different environments where someone can engage in physical activity in order to catalyze the most opportunity. And last but not least, I wanted to point to the barrier of our own attitudes. And again, I think, this session tonight is, I think disproportionately likely full of people who are savvy about disability culture and aware and have a pretty good understanding of the abilities of people with disabilities. But unfortunately, we know that that's not always the perception across our communities. And the own stigma, or the stigma that and the bias that's still so prevalent in our communities, really, I think, leads to a prominent barrier towards engagement. And this vicious cycle of inactivity for people with disabilities, where you become inactive, and because of that, you develop things like obesity or other types of chronic disease that leads to more disability, which then leads to more inactivity. So it just becomes this vicious cycle. And I think all of us have seen so many people in the community who fall into this cycle. And once you do, it's very hard to break out. And I think, thinking about how to reach people before they get into this cycle is so extremely important, as well as thinking about concrete interventions that can help to break it once people are there. But again, this small paper from JAMA from several years ago did note that adults with more severe upper or lower extremity mobility difficulty were half as likely to receive exercise counseling. So again, a mismatch between what we see happening from a public health standpoint and our ability to change our professional behaviors to match it. So when we think about the importance of physical activity, from a health standpoint, I think it's important to ask, what really is the intervention, or how do we define the intervention in a way that we know we could impact health? The guideline for the general population is here in the US is 150 minutes per week of moderate intensity physical activity. And this, of course, is vetted and promoted by our large public health agencies like the CDC, like the National Institutes of Health, for example. But the question is, do those same guidelines apply, or should they apply to individuals with different types of disability? So I'm going to take a look at that question, particularly focusing on three primary categories, that is stroke, brain injury, and spinal cord injury. And of course, noting that these conditions impact a large proportion of people across the US, and I'm sure across Canada as well. Stroke impacts almost 800,000 people per year in the US, brain injury 2.5 million. Inclusive of that whole spectrum of mild, moderate, and severe, and spinal cord injury, about 17,000 people per year in terms of new cases of spinal cord injury. And of course, many people live for many years with a spinal cord injury, and that increases the numbers. So let's start with taking a look at stroke. So we know that there is a potentiated impact of physical activity as it relates to cardiovascular health, as well as emerging evidence about neurorecovery. And stroke is one of the more well-researched conditions. When we think about what we know about the impact of physical activity, there's strong evidence for things like improvements in cardiovascular and metabolic fitness, as well as functional measures like ambulatory capacity. And there's more emerging evidence regarding some of the more some of the neurorecovery aspects and neurocognitive function. So things like improving depressive symptoms, improving executive function and memory, and reducing post-stroke fatigue. And this element of post-stroke fatigue is very prevalent, and something that is very commonly reported in individuals who have experienced a stroke. So the American Heart Association has published exercise recommendations. These are now a little bit dated, but I still think pertinent, from an evidence-based standpoint. And the recommendations outline aerobic activity, as well as muscle strengthening and neuromuscular-based activity. And I think these guidelines are quite helpful when we think about, if we really want to impact health outcomes, what should we be looking at as our threshold for engaging people in these varied types of activities. As it relates to stroke, uniquely, it's typically recommended that there is a degree of medical clearance prior to engaging people in more aggressive or more vigorous physical activity. The AHA recommends medical history, physical exam, and if there is access, graded exercise testing recommended before engaging in more vigorous exercise. And that is, of course, because so many individuals with stroke do have a vascular history where you want to be sure that they are safe to engage before really pushing them physiologically. Now, I think it's important to think about this whole realm of, the number of people who have experienced stroke and the whole concept of stroke rehabilitation. I'm, very active in that space as a rehabilitation physician. And, even in the US, where we have such a high standard of medical care, it's very clear to see that we so frequently, we often miss the mark in terms of including exercise as a key recommendation after someone experiences a stroke, and as a key component of what we call secondary prevention, meaning preventing further vascular events into the future. If you work with someone in an acute care hospital setting, or even in a rehabilitation setting, and you look at their medical plan, and there's always this listing of like, well, what's important from a secondary prevention standpoint, and usually the solution is medications. So, aspirin or Plavix, or an agent to prevent blood clots, or further clotting, and things like anti-lipid agents, and ensuring that their diabetes is well controlled and blood pressure is well controlled. But we never include exercise in that plan. And I think it's such a miss, because there is evidence to support the impact of exercise in promoting cardiovascular health in this population. So, sort of a call to action in that regard. As it relates to traumatic brain injury, there are likely effects on neurocognitive function when one engages in a physical activity intervention. So some of these very important concepts of promoting neurogenesis and neuroplasticity after a TBI, it's the focus of so much research and so much good work academically. And really, when you look at the literature as it relates to traumatic brain injury and recovery, the concept of utilizing a physical activity intervention is really just gaining speed in terms of what we understand about, what the dosing should be, as well as what the impact is. But there is some emerging evidence, for example, in individuals who experienced more moderate to severe TBI, there are some small prospective studies noting that exercise interventions can improve cognitive function and help with emerging out of the cognitive sequela of this type of injury. And as it relates to mild TBI or concussion, the paradigm has changed, right? And now, rather than locking people in a dark room for several days after a concussion, we say that gradual activity below the symptom threshold can begin after only 24 to 48 hours of rest. And that exercise can be a very potent therapy if it's timed correctly, particularly for those with more prolonged post-concussive symptoms, where there's likely an overlay of both the cognitive impact of the concussion, but also the mood disorders and other conditions that very much impact one's recovery, particularly with more prolonged symptoms. As it relates to spinal cord injury, increasing evidence regarding the importance of preventing secondary chronic disease, as well as improving functional performance. We know that spinal cord injury is correlated with higher levels of systemic inflammatory markers, altered lipid profiles, likely because of the reduced lean muscle mass that one experiences. And physical activity can really make a difference in some of these indicators. We know that tailored physical activity interventions such as functional electric stimulation can improve physiologic parameters like VO2 max. There are formal recommendations related to spinal cord injury. The most recent guidelines were updated in 2018 by Kathy Martin-Guinness, who I'm sure many of you probably know from Canada. And these outline at a minimum of 30 minutes, 3 times a week of moderate to vigorous intensity cardiovascular physical activity for promoting cardiometabolic health. And many people, take a look at this and I think that that's quite a low mark or a low threshold. So it's always important to note that that's really the foundation, right, or the base, and that the guidelines also note that increasing from there, for example, 30 minutes, 5 days a week or 6 days a week is likely to have additive benefit. So we really should consider that 30 minutes, 3 times a week to be the floor rather than the ultimate goal. And then when we think about organized adaptive sports, the space that all of you are likely working in, I think we need to think about everything I just mentioned as it relates to physical health parameters, but also thinking about the potential benefits from a mental health standpoint and important aspects of community engagement and social integration. And there's been quite a few studies looking at that, primarily cross-sectional, looking at things like anxiety, depression, self-reported social integration, life satisfaction, and even likelihood of employment. And of course, most of these point to the importance of adaptive sports in catalyzing not only engagement in physical activity, but also promoting positive peer mentoring and getting people back out there and doing the things they love that have such a significant impact on our feeling of well-being and our mood and our feeling like we're part of our communities and able to engage. Also important to mention just briefly that we should always think about at what point do we reach that threshold or even go past that threshold of engaging in so much physical activity that can be too much of a good thing, and thinking about the potential risks of a high level of engagement from the standpoint of things like overuse injuries or other sport and physical activity related medical illnesses. And we've done quite a lot of work on this in the Paralympic space. Dr. Emery has also been a part of many of these studies where we've looked, at injury and illness reporting in an elite Paralympic athlete population and have started to define what those injury patterns look like. We know that elite athletes can experience musculoskeletal injury. The upper extremity is typically the most impacted in a Paralympic athlete population. And we know that one is also at risk of things like skin breakdown, or for those who have autonomic an autonomic component to their injury, for example, spinal cord injury, thinking about things like thermoregulation or orthostatic hypotension or even autonomic dysreflexia. So this isn't the primary focus of this talk, but just wanted to point out that, we do have to think about the other end of the spectrum for people with disabilities who are engaging in a high level of physical activity, where we actually may not need to think about, well, what might be the impact of that high level of engagement from a health perspective. But going back, of course, to the primary point of this talk, which is the fact that most people have a risk of engaging in too little physical activity as opposed to too much. And that's really, what we're thinking about solving for with so many of our community-based adaptive sports programs. So the next portion of the talk, and really, bringing it home, is thinking about, how should we frame and think about sport and physical activity opportunities. And, we've looked at what we know are some of the known health disparities, as well as what the intervention should look like if we want to impact health. But I think it's important now to also broaden that lens and to understand that, yes, adaptive sport and physical activity can be important for health, but it's also a right. And when we think about our societal lens on disability emerging from a medical model into more of a social model and more of a human rights model of disability, it's so important to remember that access to these opportunities is really a rights-based issue, and something that we have to ensure everyone has access to as part of their, part of their rights across society. And thankfully, although many of us, I think, would support this notion, we have both, national and international groups that are backing us up. So, for example, the United Nations in 2006 published the Convention on the Rights of Persons with Disabilities. This has been ratified in most countries across the world. And when these, great big thinkers, people bringing that global human rights context around disability, when they were drafting this document, they included sport. And I think it's really important to note and to talk about that and to educate people about that. That Article 30.5 of this large human rights document talks about the participation in cultural life, recreation, leisure, and sport, noting and bringing forward the fact that participating in leisure and sport is part of our rights as people with disabilities, and just as important as the right to health, the right to education, or right to stable housing, and all these other things that we always consider to be core tenets of civil and human rights. So yes, it is a rights-based issue at the end of the day, and that's increasingly recognized globally. Here in the U.S., I know that this may not be as pertinent to programming and activities in Calgary, but I do think it's an important precedent to note that here in the US, the Department of Education, which has, of course, for decades promoted integrated education and, upheld the expectation that students with disabilities have the right to be educated alongside their peers in the public school system, that in 2013, they went a step further to also publish what we call a Dear Colleague letter, which is just a fancy way of saying, a letter that's published to clarify the intent of the law. And this Dear Colleague letter noted that access to physical activity and physical education is considered to be part of integrated and inclusive education, and that just as we know there's an expectation and a legal obligation to academically educate students with disabilities in an integrated environment, the same expectation exists for sport and physical activity. Now, there's been, several best practices in states where this has been implemented in a pretty impressive way, but also large swaths of the US where it's not being implemented at all. So this is an example of something that is on the books and exists in policy, but is unfortunately not broadly known. And for that reason, it's very easy for schools and school districts across the country to simply, frankly, ignore it until there may be a student or a family that calls them out and says, no, actually, I do have a right to engage in, integrated physical education or sport. And so a lot more work to do, but very important to note that this is also documented as a rights-based issue at the national level. And as is often the case, it is the athletes themselves that push the envelope towards implementation of many of these mandates. A great example here in the States is Tatiana McFadden, who's a very well-known elite Paralympic athlete, multi-time medalist. But before she was famous, she was a high school student who wanted to compete with her peers on their high school track team. And she was unable to train with the team, but wasn't allowed to score points for the team, and wasn't fully included. And she and her family brought suit against the Maryland Public Schools Athletic Association and won. And that led to the passage of the Fitness and Athletics Equity for Students with Disabilities Act, which changed the expectation under the law in that state. And what you see is that then sets precedent for other states around the country. And this has been a really important area of progress. So just want to point that out, because we often do see this come from the ground up, right? And that the actual change is really led by our athletes themselves. At the collegiate level, we see some moves towards inclusion, but there's a lot more work to do. Here in the U.S., we have, our large NCAA, the National Collegiate Athletic Association, which is really responsible for, all of the rules and regulations around sport, competitive sport at the collegiate level. And, we've had examples where legislation like Title IX has led to sweeping changes in the right to participate for example, women. And Title IX, which was passed back in the 70s, totally changed the context of women's sports in the US, because it mandated that colleges and universities had to develop equitable opportunities for female athletes. And unfortunately, we just haven't seen the same degree or level of progress towards athletes with disabilities. And so at the collegiate level here, it's far more piecemeal, right? Where there are many colleges that have great programs, but it's because someone at that college cared enough to want to start a program. And many of those programs are based in, student disability services or club sports or intramural and recreational sports, rather than at the varsity sport and NCAA level. So this is a very active conversation and a big area of advocacy here in the States. And, we'll see what happens, but, and I'm sure we'll see change over time, but something that's still very much to be determined. So, what is the road forward? So I'll end on a positive note, right? And thinking about what are the solutions and what's the call to action. And I put it like this: I'd say that the barriers are real. We know that these barriers lead to significant health disparities. But the question really is, how do we change societal expectations on our own around engagement of people with disabilities in physical activity? And I think there's two key steps here. The first is to really begin to advocate for sport and physical activity through this lens of universal design. And the second is to use our voice to advocate for expanded opportunities, particularly for those of you here tonight who are engaged in research and education, and driving and demonstrating the evidence that backs these programs up and shows the efficacy of these programs, but then also involved in spreading the word and thinking about translating that knowledge into the community. We have a really powerful voice, and it's important to understand how we can leverage that. So when we think about the lens of universal design, probably a concept that many are familiar with, but in case not, universal design is really a concept embraced broadly across the disability community and the disability rights movement. And it's thinking about design that works for everyone, inclusive of people with disabilities, but not a disability specific concept. So it's thinking about how we design our communities, both the built infrastructure, but also the programs and the tools that we use and the policies that we create so that they are as inclusive as possible from a universal lens from day one, right from the start, so that we don't have to then go back later on and to retrofit or to think about, well, how do we need to adjust or augment to meet the need of just people with disabilities and consider it like a side issue, right, or an afterthought. So universal design is really powerful because it, demonstrates that if we think about inclusion from the beginning, we create more efficiency, we create more universal environments, and we simply make everything that we do have greater impact. So it's important to think about how we apply that universal universal design lens to physical activity. So for example, as it relates to infrastructure, here in the US, the primary piece of policy that protects against discrimination on the basis of disability is the Americans with Disabilities Act, or the ADA. And the U.S. Access Board is a group that's responsible for thinking about, how do you translate the ADA into different environments? And they've created these checklists for public fitness facilities. And it's, I think, really a fantastic tool that is very much underutilized and not, people broadly, many people don't know about it. And this is a really simple way for any public fitness facility to simply, download them, take a look, and begin to implement small changes that can very much make the facility more universally accessible, again, for everyone, not just people with your traditional disability, for example, like a wheelchair user. And I think if we were to raise awareness about this and encourage some of our mainstream fitness facilities, particularly those large chains where there's hundreds of them, across our countries, that we can really, really make a big difference with a very, small investment. Universal design also applies to tools and materials. And when we think about that barrier that was described in the Jim Rimmer paper about not having tools, the correct tools and materials to use in fitness facility, it's important to note that if we think universally, there are easy solutions. One example that I like to point to is something called the crank cycle. And I know I'm not engaged in paid advertising for the crank cycle, but I do think it's a great example of type of fitness equipment that can be used by anyone. So it's basically a spin bike or a hand crank or a crank, but for your upper body. And if you're able-bodied, you can, of course, pull up to it, crank. You can choose to leave the little seat in place, or you can move the seat to the side so that you can stand and engage your lower extremities and your core while you crank. If you're an adult who may have something like, limited balance, for example, you can leave that seat in place and simply use it as a tool to assist with balance while you crank. If you're a wheelchair user, you can either transfer onto the seat if you have good balance, or just simply move it to the side and stay in your chair. And it's easy to see that it's a pretty universal tool. And, how great would it be if we would change our expectations so that most of our mainstream fitness facilities, in addition to a room full of spin bikes, also had a room full of crank bikes. And anyone, whether you have a disability or not, could go to the gym that day and decide whether they want to take a spin crank or a crank class, a spin class or a crank class. And I bet you a lot of people would choose the crank class because it's good for your upper body strength. It's great cardio. You actually get your heart rate higher with cranking with your upper limbs as opposed to spinning with your lower limbs. And it would simply give people the autonomy to choose, right, and make it more universal rather than creating a separate sort of standalone program for people with disabilities. The picture on the bottom right is an image from the Lakeshore Foundation, which is based, many of you probably know about it, fairly well known, based down in Birmingham, Alabama. And it's a fitness facility that's designed for people with disabilities, but also open to members of the general public. And they have multiple crank classes a day. And you can see an image here of an able-bodied crank instructor teaching a class to a mix of people with and without disabilities, some wheelchair users, some people who are sitting in a standard chair to use it, and so on and so forth. So again, very universal. Universal design can apply to programs. I think one of the best examples of this is the sport of sled hockey, where many community programs fill team rosters with a blend of people with disabilities and people who don't have disability. And at the community level, I think it makes perfect sense because it, enables you to fill more teams, which leads to more exciting tournament play, more available tournaments, enables people to play alongside their peers and family members. And then as you move up through the ranks of the sport and get into the sub-elite level, then the rules change such that then it is tailored to the elite athlete with a disability, which of course is important for that Paralympic pipeline. So to me, I don't see why we don't do this with all of our sports. Like at the community level, why shouldn't it be all comers? Where an able-bodied person can play wheelchair basketball right alongside their teammate who may have a disability. It would infinitely increase awareness of the sports. It would, really foster a sense of inclusion and universality around those opportunities. And then, again, as you move up the ranks, it becomes a more disability specific activity. But I think this type of concept is exactly what we need from a programmatic standpoint to really move the needle toward inclusion. And finally, ending with that call to action. So, I think it's so important to remember for those of us who are involved in clinical care or research or knowledge translation or public health that, we really are a trusted source of advice. We're powerful community advocates. And many of us are engaged in research that explores the outcomes of these programs and really tells the story in a data driven way. And that's so incredibly important when we think about implementing change. And ultimately, again, bringing us back to that paradigm shift. I started the talk with that image of the sort of old school wheelchair symbol with the newer, more cutting edge wheelchair symbol. And again, it's creating that paradigm shift towards understanding that if you have a body, you're an athlete, and all of us can move and engage in physical activity. Nike coined this phrase actually several decades ago, but I think it very much rings true for the conversation we're having tonight. And they've done a lot around universal design. This is an example of a grip that they developed for the bottom of a running prosthesis so that a runner like my friend Sarah Reinerson, who's depicted here, can go on a jog on the track, but she can also go off track if she wants and think about trail running or running in other environments, really to open up the outdoor environment to her being able to decide. And they've done a number of innovative things in a similar vein that I think have really helped to shift our concept. So wanted to end with just a couple of great resources. So that CDC vital signs report that I noted towards the beginning of the talk is a great repository of information. If you're interested in knowing some of the, what is the evidence to support these types of programs, they have great infographics that if you're working in a clinical environment or in a place where you're looking to disseminate, that you can easily use these tools. I just took a screenshot of the one on the left, which I think is awesome for really in a a nice, attractive way, thinking about how can we increase physical activity among adults with disabilities. Another great professional resource is the American College of Sports Medicine. And they partnered with NCPAD, or the National Center on Health, Physical Activity, and Disability, several years ago to create a certified inclusive fitness trainer certification. And ACSM is it's a US-based organization, but with international reach. So anyone around the world can get this certification. And it really, enables people working in mainstream fitness environments to get that extra bit of training to feel comfortable working with clients with disabilities. Doing a little bit of a deeper dive on NCPAD, this National Center for Health, Physical Activity, and Disability, it's a great repository of information. If you go to their website, you'll see that it's divided into sections for health professionals, fitness professionals, individuals with disabilities themselves and their caregivers, and really is a one-stop shop repository for, looking at the evidence, but also tools to get people moving. So things like online exercise classes, fitness guides, etc. And I know I've pointed a lot of people to this, especially through COVID, where more people are looking to engage in physical activity in their homes rather than going to a facility. A lot of great programs out there. And, this I realize is fairly specific to our environment here in Boston, but I'm sure that this is what the hub is doing, right? From what I understand, is bringing together these different programs all to have a more unified impact. And all of you are out there doing the important work, right, to change community-based opportunities and to promote community-based opportunity. And hats off, because I know it's not easy, but it's so important for tailoring these opportunities to people with disabilities themselves. So ending with the key points, we know that these health disparities for individuals with disabilities based on sedentary lifestyles are very real. We see it anecdotally, and it is borne out in the evidence as well. Access to sport and physical activity should not be seen as an extra or a nice thing to do or something that you get to if you have time, but rather a critical component of inclusion and disability rights. promotion of universal design in sports and physical activity, I think, is really the most critical next step to changing the paradigm and bringing it out of being a disability specific only concept where people silo it, right? And they assume it's not their problem, right? To instead thinking about it as a concept that empowers everyone in our community in a universal way. And ultimately that we can be agents for change. So I'll end there. I want to thank Calgary Adapted Hub for this invitation, particularly Dr. Emery and Dr. Legg, Elisa for chasing me down for deadlines and slides. Thank you very much. And many colleagues, mentors, and friends along the way. The picture on the right is a young woman in our community here in Boston who has spina bifida, and she is 10, and she has a hot pink everyday chair and a hot pink racing chair. And she's the future, right? I'm pretty sure she'll be on the track in Los Angeles or wherever the games are in 2032. And ultimately, you know, all of this change that we're striving for now will impact young athletes like her, which I think is so exciting. So I will stop the screen share now, and happy to take any questions.
Thank you, Cheri, so much. So for questions, just for ease of things, and the bottom of your screen, you'll see where it says reaction. You can use the raise hand function, or feel free to pop a question in the chat and I will moderate for us. And I'll kick us off here, Cheri. Thank you so much for the chat. I have worked a lot in the disability field, and one of the things that really spoke to me was your slide about education and the right to be a part of physical activity classes. And I work with a youth with cerebral palsy, and his gym teacher this year told him he wasn't able to participate. And how would you go about trying to teach that, or like get a child to advocate for themselves in that way?
Yeah, well, I mean, I think that, you know, ultimately, you know, I think that it's challenging. You know, there's going to be a difference in the level of comfort for especially young people in self-advocacy, right? And some are going to be very comfortable with that and able to do it effectively, and others aren't. And I always say that, you know, you shouldn't have to be a self-advocate to have the opportunity. So ultimately, I think the most important person to reach in that scenario is the instructor and the school, and really tackling it from more of a systems level, and thinking about like what's the rationale behind that decision, and trying to unpack that a little bit, because you know, whenever there's this black and white, you can or you can't, usually we know that people are thinking in a too linear of a way and that they probably aren't aware of both their obligations, you know, from an inclusive education standpoint, but also probably just not aware of the paradigm we're talking about tonight, right? And probably are over medicalizing that child and or that young individual, and are, you know, putting their own implicit bias onto that situation. So I think it has to go back to the instructor themselves in the school.
Thank you. So from Emma Partridge here, she's wondering if the barriers that were reported in the different studies you spoke about, were they the same for both the pediatric and adult populations?
Yeah, you know, it's a great question, Emma. This talk was definitely adult focused from the standpoint of looking at that evidence. So, and I do think that's where most of the literature is. You know, I think that the barriers probably are a little bit different for young people, and that wasn't presented tonight. But I think, you know, and there is some literature out there, but not quite as much as what's noted in adults. And I think for young people, you know, so much of it goes back to the learning environment, as we just discussed, and also things like the impact of parents, right? and parents' own belief systems. But I frankly don't think there's a lot of literature out there on that. So I don't know if you're engaged in research, Emma, but it would be a great research question. We're doing a small study currently at our institute, looking at the impact of peer mentoring for adolescents. So pairing adolescents with cerebral palsy and spina bifida with young adults with the same diagnosis. And those young adults are sort of adopters, so to speak, so people who are engaged in adaptive sport. And looking at and we have a intervention, it's a little small pilot study right now, but we have an intervention group and a control group, and looking at, does that peer mentoring make have major influence on the level of engagement in physical activity. So, and I can tell you that it's a small pilot because that type of work it's not done very often. So I think it's a wide open area for research.
Wow, that study sounds very cool.
Yeah, I'm very excited.
I have one more question here from David. Why do you think equipment like the crank hasn't been widely adopted?
Oh my gosh, I just think there's such a, I think that there's such a, what's the word I'm looking for? The momentum towards not changing is so strong in these large gyms. I mean, here in the US, the landscape is, you have these big companies that have mainstream gyms in multiple cities and urban settings across the country. They all have the same equipment in every single one of those gyms. And those are the facilities that you see most frequently in the community, right? And I think that the momentum is so strong towards like that being the norm, that breaking through that, I think, is just very challenging. And I think it goes, I think it's multi-layered. Everything from like those mainstream fitness facilities having contracts and deals with the people who make the equipment that they have. The majority of people coming into those facilities having specific requests for that type of equipment. And again, because of all the barriers were discussed, so few people with disabilities being at the table to be included in those decisions. So I just, I think it would have to be an uprising, but hopefully we'll get there. Or, well-known, well-known high-profile champions, I think could also make a difference.
All right. Thanks, Eliza. So I'm just going to wrap up with a big thank you, Cheri. Thanks so much. I don't know how there's enough hours in the day for you to accomplish what you do. And I want to thank you for spending this time with us and for being our inaugural speaker in the Calgary Adapted Hub, powered by Jumpstart Research and Community Engagement Seminar Series. And that's a mouthful. As usual, I always learn something new and really appreciate your passion, your dedication to evidence-informed practice and policy, now from the lens as a physician, an athlete, a researcher. And as an international leader, you lead by action, and we want to thank you for your dedication to inclusive and active future universally. And I'm going to give the last word to our leader, which is Dr. David Legg, just to say thank you, and it's really great to see you, Cheri.
Thanks, Carolyn.
Thank you, Dr. Emery, for this opportunity. And Dr. Blauwet, Cheri, it's great to see you as a friend and a colleague. We really do appreciate you helping us launch this knowledge translation seminar series. We're looking very forward to the ones that are coming up. Eliza, I don't know if we're able to start promoting those yet or not. So perhaps if I may, I'll pass it back to you for one final promotion for some of the speakers that we have coming up. And to Karen Dummett, our program manager, thank you so much for arranging this. This has been a fantastic start. We're very excited. We're thrilled about the opportunities that are presented for us here in the Calgary Adapted Hub powered by Jumpstart. So Eliza, perhaps over to you just for some I don't know, some crumbs about some of the potential speakers coming up in a couple months. If we can provide some teasers, that would be fantastic.
Sounds good. So our next month's speaker for March is Dr. Nancy Quinn out of Western University. And honestly, Dr. Blauwet could probably tell us more about the speaker after that, as it's in April, it will be her husband, Eli Wolf.
Oh, I'm sorry.
And Cheri, I don't know if you know, but Eli was on earlier with Stella, and she was waving at you, trying to get your attention.
Oh, was she?
Yeah, I loved watching it. Yeah.
Oh, that's awesome.
Well, thank you everybody for joining us for our inaugural session. We look forward to seeing you again, and have a wonderful evening. Good night.
Thank you, everyone.
Thanks. Bye, everyone.
Great job, you two. That was awesome.
Thank you.
Really good. Really good.
Good kickoff, I'd say.
I was really happy with that. So yeah, congratulations. That was very well done.
Thank you. Have a great evening.
Thank you. You too. Yeah. Enjoy your Thursday night. Okay.
See you.
Yeah.